All right. Well, my name's Lauren. I think I met you guys a few weeks ago. Um, so this is kind of a collaboration that me and Dr. Kasab kind of talked about, kind of starting a journal club that combines like pulmonary critical care and neurology, since we're going to have a lot of shared patients moving forward. So this is the first of that. So today I'm going to present on the Telstar trial, which is treating rhythmic and periodic EEG patterns in comatose survivors of cardiac arrest. Oh, sorry. Is it even on? Is it on? Okay. All right. So for just a few objectives, we're going to review a previous trial that had come out that was similar to this, that also looked at rhythmic and periodic patterns, review our current trial, and then discuss how this could apply to our patients. This was originally published in February of this year in the New England Journal of Medicine. Just a little bit of background. So rhythmic and periodic EEG patterns have been reported in up to 35% of comatose patients post-cardiac arrest. Clinical seizures are often infrequent in this population. However, generalized periodic discharges, or GPDs, are common, and they're all associated with poor neurologic outcomes. So currently, kind of one of the big issues is the practice is not standardized in what we do to treat this patient population. So some providers do a stepwise treatment, like what we'll see in this trial. Some decided that it's futile due to poor outcomes associated, so they do not treat. And then some treat, but it's just kind of random in what they decide to do, whether they use AEDs versus sedatives, and no apparent standardized method. So there was a previous trial that came out in 2018 while this trial was actually enrolling, but it was at a single center. And it included 166 patients. So they looked at EEGs in combination with 4 prognostic indicators. So they looked at brainstem reflexes, the N20 cortical responses, NSC levels, as well as neuroimaging. So currently we don't do 2 of the 4 of these. So we look at brainstem reflexes and neuroimaging typically here. We don't do the other 2. They found that survival and good neurological outcomes, which they used the same scoring tool as this current trial with cerebral performance category scale scores of 1 or 2, which are associated with good outcomes at 6 months, favor treating patients who have benign EEG patterns as well as refractory status epilepticus. However, they also said that GPD patterns may be associated with unfavorable outcomes in combination with poor prognostic indicators, so in line with previous literature. So the Telstar trials, their primary objective was to estimate the effect of medical treatment on EEGs, status epilepticus, on neurological outcome of patients in post-anoxic encephalopathy after cardiac arrest. So for their study design, it was a multi-center clinical trial. It was randomized treatment assignments. However, it was an open label. They did have blinded endpoint evaluation. So the people who were evaluating the primary endpoint were blinded to the treatment. It was completed in 11 ICUs across the Netherlands and Belgium. And one big thing with this was they did use continuous EEG monitoring. So for inclusion of the trial, they were at least 18 years of age, had a GCS less than 8, post-cardiac arrest. They were enrolled in the trial within 24 hours of achieving ROSC, and they must have had rhythmic and periodic EEG activity. So they define this as periodic discharges, rhythmic delta activity, and then spike and wave or sharp and wave EEG patterns. These patients had to have a minimum EEG activity of at least 30 minutes or 2 5-minute intervals within a 60-minute time frame. So as someone who is unfamiliar with what EEGs look like on a regular basis, I included this just more for my own knowledge and the other people in the audience who don't regularly read EEGs. So for the first one, in letter A, this is a benign EEG pattern. B is refractory status epilepticus. C is a generalized periodic discharge pattern. And then D is a malignant non-epileptiform EEG pattern. So what I didn't know was what a GPD looked like on EEG. So that's kind of why I pulled this from the previous trial I had mentioned. I just wanted some examples. So for exclusion criteria, patients were excluded if they had a limited life expectancy of less than or equal to 6 months. Their GCS was less than or equal to 3. They had progressive brain disease, so a brain tumor or some kind of neurodegenerative disorder, a reason to withdraw care other than a neurological condition, or a known allergy to any of the treatment medications. So as far as intervention, so they did treatment, standardized anti-seizure medication, plus the standard of care versus standard of care alone. So for the treatment, they did it in a stepwise fashion. So you could receive a benzodiazepine infusion plus one AED. They started with phenytoin unless it was a contraindicated, and the other two were valproic acid and Keppra. However, you'll see later that phenytoin wasn't the most popular option. Keppra was, kind of, which is to be expected. In step 2, you would add a second sedative agent, which was propofol plus a second AED, and continued the one from option 1. And then the third step would have been put them into a barbiturate coma. They used thiopental. I guess that's the European more standard of care than arfentobarb. And then after the initial doses, they were used EEGs to guide the barbiturate comas. Our primary outcome was neurologic outcome according to the Cerebral Performance Category Scale score at 3 months. So a CPC of 1 and 2 is associated with a good outcome. However, 3 to 5 is considered poor. So you can see severe disabilities, coma, and death. For secondary outcomes, we looked at mortality at 3 months, ICU length of stay, seizure recurrence, and then duration of mechanical ventilation. And then for safety outcomes, they just looked at what was considered a serious adverse event, which is what would be considered life-threatening. However, the outcomes were not reported for 6 and 12 months in this trial because they have not been analyzed. For statistics, their primary outcome was done using an intention to treat principle, so everyone who was enrolled was included in the primary outcome. They did risk difference, which is a between group difference in percentage points of a poor outcome with 95% confidence intervals. And then our secondary outcomes were pretty much standard parametric and non-parametric tests. As far as population, so they started over 2,500 EEGs, but only enrolled 172 of those. So of the 2,500, about 350 had the required rhythmic and periodic EEG activity. And then of those 354, only 172 were included. The difference in those are mostly just missed inclusions, withdrawal of care, or no informed consent. And that left us with about 80 patients in each group. As far as baseline characteristics, mostly males of a median age of 65, with out-of-hospital cardiac arrest being the most common, with presumed cardiac. What I did think was interesting was their median time from cardiac arrest to ROSC was actually pretty short in comparison to kind of what we see, at least for here. We tend to code patients a lot longer than 16 and 19 minutes. So pretty shorter window of ROSC. Then I included all the baseline EEG characteristics. I asked Dr. Kassab to talk about it because this is not my forte and I didn't want to just, assume I know what I'm talking about because I don't. So if you want to come talk about this, at least this piece of it, that would be great.
Basically on the slide, it looks like, let me see. So they included all these periodic patterns, generalized periodic discharges, but everything is above 0.5 hertz. And then the electrographic seizures confirmed are above the 2.5 hertz. And it looks like they're actually spread even among the two groups. So in my mind, really, there is no difference in the periodic patterns. I would personally, just my personal, when I was reading it, preference, I would love to see a little bit more of the evolving patterns and electrographic seizures than the 9 and 2 over there, because if these hold with the same conclusion, that means much more than just a periodic pattern in general. But and any question about this slide?
The other interesting thing is there's a relatively diverse swing in the background. Not huge, but
Right.
A little bit less matched than the patterns.
Correct.
Thank you. All right, so for our primary results of our primary outcomes, so our CPC scores associated with poor outcomes of 3 to 5, they found no difference. So with a really wide confidence interval too, and and a non-statistically significant p-value. So essentially 90% of patients in both groups were associated with poor outcomes. As far as secondary results, pretty similar to the primary with poor CPC scores at between 2 and 5 months and 4 and 5, and then ultimately about an 80% mortality associated with our groups. And then as far as an ICU length of stay, it was, I guess the one column on the left, which I cut off, is the treatment group and then versus control on the right. So our mean ICU length of stay was longer in the treatment group, as well as our mean duration of mechanical ventilation. The authors did note that no definite conclusions can be drawn from their secondary outcomes because they did not take into account any adjustments for their confidence intervals. So as you can see, they're really pretty wide, just like the primary outcome. So as far as the anti-seizure group, majority of patients were on at least 2 anti-epileptics if they were on the treatment group. And then if you look at the sedatives used, more patients ended up on at least two sedatives versus 1. And then if you look in the control group, majority of them were on at least 1 sedative to account for both myoclonus and them being mechanically ventilated. And then if you look in the total, at least greater than or equal to 1 anti-seizure drug was continued the entire period of their ICU admission, with about 97% of the ones in the treatment group. So I pulled this from the supplement. So majority of patients did end up on Keppra over phenytoin, which is what their initial recommended drug was if you were to follow the treatment group. With Versed being the second most common drug used as their primary sedative over Ativan, which should be standard of care. So I just put some example meds because they quoted median maintenance doses of 0.1, and I was like, well, what does that mean in comparison to kind of what we would see in our patients? So roughly a median of 7 milligrams an hour if they're a 70 kilo patient. And I did the same for propofol. I just converted it to mics per kilo per minute, which is what we would see in our charts here. So if they were 70 kilos, about 13 mics per kilo per minute, which is actually a pretty low dose propofol compared to what I typically see in our sedated patients, or if we're using this for seizures and sedation. The median Keppra dose actually came out to be about 800 milligrams twice daily if you were to add that up, which I thought was interesting because normally we would see like 500 to a gram, so right in the middle. So maybe they just do a lot of 750s. I don't know. So as far as our anti-seizure group, we had complete suppression of EEG activity for at least 48 hours in about 50% of our patients in the treatment group. And then if you look at suppression of the rhythmic and periodic patterns, at 24 hours, we had a complete suppression of about 70% of our patients. And then after up to 48 hours, still roughly the same at about 70%. So this was what they called their exploratory pre-specified analysis, because this is really not powered for any kind of true evaluation, because this is the patients who had, quote, a good outcome. So as you can see in our control group, only 7 patients had a good outcome. And then in our anti-seizure treatment group, only 9 patients had a good outcome. So really you can't take a lot away from this, but they just felt, I guess, the need to include it. So as far as generalized periodic discharges, you can see that the control group had better outcomes in comparison to the treatment group. And then when you look at seizures, more people in the seizure group who are ultimately treated. So you can look at the forest plot and it kind of favors the anti-seizure side of that. And then same for the other category, which I wasn't entirely sure how to interpret what other was in this. So you guys would probably know better than I, but it also favored the anti-seizure med section. Okay. I was just like, they didn't ever define what other was, so I didn't want to guess. And then if you look at the onset of activity, from what I've read, it said that GPDs typically don't start until later on after cardiac arrest. Like you can see some, but then they don't evolve to the amount of hertz necessary to register on an EEG. Hopefully I'm saying that correctly, until about 24 to 48 hours. But there is really kind of no difference. So all of these, they cross the forest plot for the most part, so you really can't take away anything that it technically favors one side or the other. Plus, just very few patients were included. As far as strength of this trial, it was prospective and randomized. They did use continuous EEGs, and then the outcome assessors were unaware of their assignments. As far as limitations go, there was a higher mortality within 24 hours in the control group. They attributed this to withdrawal of care not being balanced between the two groups. So they were more likely to withdraw care in the control group versus the treatment group. The use of sedatives as an anti-seizure treatment could have potentially delayed the withdrawal of care. And then the physician and EEG readers were also aware of the trial group assignments, so there's potential for bias there. And then when this trial was going on, we were still cooling patients. Majority of them were cooled to 33 to 36 degrees. However, that's no longer practiced based on the TTM2 trial that came out last year. So that potentially is something new that we will see that may make this a little bit different. So in conclusion, the authors said that in comatose patients post-cardiac arrest with rhythmic and periodic EEG activity, intensive anti-seizure treatment for at least 48 hours did not improve outcomes at 3 months. So you can't rule out benefit or harm of using aggressive treatment, anti-seizure treatment in this population. So this is some of the discussion points that the trial included, but I really just kind of wanted to open it up to everyone. So anything you guys want to add, feel free to just jump in. But they decided that the standard of care in the control group for mechanical ventilation, they both use sedative meds. So was there potentially a decreased difference in outcomes due to cessation of myoclonus and the rhythmic and periodic patterns in the control group? Intensive seizure treatment did not result in fewer outcomes. Intervention was associated with a longer length of stay as well as mechanical ventilation with no difference in mortality. So the mortality in this trial was in line with all the previous studies. And then if GPDs are associated with anoxic encephalopathy, it could be a direct expression of severe ischemic brain injury rather than epilepsy. So this is my version of application of this trial. So do we treat this? I feel like there's a lot of ethical issues that surround this potentially. Do we treat the seizures knowing that there's a poor outcome and just delaying the inevitable versus do we treat them because we see that they actually have seizures? But ultimately, the end is still the same. So they still have a high percent of mortality and potentially no change in their overall outcome. They have increased time on the vent, increased hospital length of stay, which is increased hospital costs, knowing that there's no difference in the outcomes. And then since we're no longer cooling patients post-cardiac arrest, I don't know if this will change the number of patients we see with seizures or potentially an earlier onset. You know, typically when we cool patients, from what I understand, you get a slower EEG pattern. So I don't know if that will increase the frequency we'll see that or the earlier. So I think that might be at least cause for another trial now that we're no longer cooling them. That's so true. The,
so you may have just like some mitigation, but if you decide to sort of like treat aggressive seizures, that you'll just have to clean them. So unclear how that would change them.
That's a good point.
Yeah, I think you have this kind of you're looking for that diamond in the rough patient with these types of patients, that has a typical outcome, right?
Mm-hmm.
And there was a study I wish I recalled it often where they looked at myoclonic seizures after cardiac arrest, and some of the patients had different myoclonic patterns and more like vertex waves on EEG. In my mind, probably earlier, Lance Adams, presented earlier, did well compared to the traditional myoclonus. So I think you have to be kind of look at the whole picture, in terms of prognostication, and not be too quick just to kind of this is a lost cause kind of thing, because there are those diamonds in the rough.
Right, the ones who you never think will do well that ultimately do survive and do have good outcomes.
But looking for those characteristics, there are specific characteristics of those patients on EEG, or vertex predominant, discharges.
Is that like those 4 characteristics of prognostic indicators from the previous trial? Does that fall into those?
No, this is a different kind of thing. I'll have to pull that EEG trial. I was looking at that during my fellowship. You probably maybe remember that too, right? And the last thing would be, also the patient selection. Kind of, do we really know the story? Do they truly have a cardiac arrest? If they're a patient that has epilepsy, had a huge seizure potentially that was found like a arrhythmia or cardiac arrest, maybe it's more of a downstream effect of the seizures,
right?
Status epilepticus, and they might be a candidate that would do much better with aggressive treatment, you know, as opposed
Mhm.
to someone that just has no history of epilepsy and is found down. So
Right.
it could matter a little bit based on the history in my mind.
Well, when they were talking about the multimodal prognostication, that was not necessarily including the serial neurologic exam, which actually has pretty good sensitivity and specificity, particularly if, for example, from the like bad side of things, if they don't have a corneal reflex at 48 hours and they're not cooled, then you have a pretty high likelihood they're not going to do well. And so, like, potentially, if you were going to do like another study in future, you would really try to like single out the patients that were the most likely to do well and only look at them. That would be probably the easiest way to come up with the sort of even the people who have favorable characteristics.
Mm-hmm.
Do they do well if you aggressively treat them? The number of patients that fit that though is going to be very, very low.
Like even this trial's enrollment period was really long. So, and it took them that long to get 88 patients in each group, and they started at 2,500 EEGs on patients. So,
Yeah.
But they've done enough studies at this point to know that, like, for example, you know, they tried to sort of exclude people, right, that had like significant medical comorbidities that were going to like lead to death within 6
right,
months or
that they were going to do
something like that,
poorly
right? But
anyway.
you would, you know, choose like the younger patients, like the shorter downtime, the sort of arrest rhythm that like was most favorable to, you know, really good return of circulation, like VFib or PAC, and then you would also choose those patients that had like their brain stem intact and all the other features. But it would be difficult to do that. And what it comes down to, I think, for a lot of patients, families end up making decisions that very painful for them to see their family members in that position. And some are very clear that the goals of care their loved one expressed would not be to be in a situation where they couldn't enjoy their previous level of independence.
Right.
So, I mean, even like some of the CPC sort of grades, like it's really only like 1 and 2, like you still have a significant amount of disability.
Right. 2 was still kind of pretty bad.
Yeah, exactly. So that makes it a little bit challenging because what you're coming up against then is like these ethical considerations don't just necessarily go in the direction of like provide all the care, give everything that you possibly can, but also other direction, respecting the patient's wishes, not accepting the patient.
Right.
We believe this data, you know, that maybe spot EEGs alone become sufficient more for prognostic. Like you should never use the EEG for prognostication. The clinical picture actually.
Yeah, it's like all of it together. It's like the exam plus the EEG plus
but maybe you want to add that to just make sure the full picture is being understood. But maybe you continue. Doesn't sound like it. Probably at least one EEG just to add to the picture, the routine EEG. Make sure you know.
I guess the other part of it too, right, is that like if you put somebody down close to birth suppression or even before then, you could potentially be interfering with the neurologic exam, which is like day-to-day influencing what people are thinking is most likely to occur. And even though you try to tell the family, like, hey, like you might sort of missing part of the exam because we're trying to aggressively treat seizures, they still can't help but see that their loved one isn't looking good.
trial.
In the patient where this originally came up, they had seizures on EEG, and all the neurology decided to do was just up the sedative. So like we went from like 12 of Versed to like 20. Like we didn't actually add any anti-epileptics, and so that would kind of raise the question of like, are we going to treat the seizures, or are we just going to sedate them further and hope that this plays out? Like he wasn't doing well either way, but it's like the addition of the anti-epileptic at what point?
Although, like, you said Versed.
Yeah, they were on high dose Versed.
Yeah.
Right, but I was just
because
thinking
it's
like
for seizure.
a different mechanism. Like-
Yeah. I mean, I think that when people add Keppra, in these sort of situations where we're like worried about myoclonus and that sort of thing, it is honestly sometimes just to make the movement go away.
Right, yeah,
So that the family isn't
seeing that.
Yeah, I've heard, some epilepsy experts, like, I talked to Dr. Peter Kaplan, who's one of the most well-known in the field. He was sort of advocating, and this is not evidence-based, but expert opinion, low smart evidence, but just treating any patient with myoclonus with something like Keppra to see if it would help, because even if it's not, like cortical myoclonus, it still may be helpful and it's sort of worth a trial either way. So, there are different opinions out there. It is hard. I think there is room for expert opinion on these cases, because these cases are a little different. And we are
Right.
kind of looking for that 1 out of 100 person. Yeah. Yeah, there's been a long-standing debate even about the importance of treatment of non-convulsive status epilepticus. I think people are kind of winning out on the treatment side of that one, though. I think that battle's been fought and won, but there was, for 20 years, I think there was kind of a back and forth. Just unknown how effective and how. Sure. Thank you. It was great. Appreciate it. Thanks so much. There's so many factors and variables. It's hard to
You're welcome.
isolate one. It's like if you